Please start.
Good evening, doctors. Warm regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. Mehalakshmi ma'am. Ma'am is a senior consultant medical oncologist and head of the department from Nizam Institute of Medical Sciences, Hyderabad. Ma'am will take over the session, set the contest, and then she will invite the other faculty. Ma'am, over to you.
Good evening, everybody. Thank you, Sandeep, and I thank the Bayer team for the opportunity. Today, we'll be discussing the new treatment options in the management of metastatic HSPC. Today, we have two speakers, Dr. Stravya and Dr. Rohit Reddy. After that, we'll have a small case presentation. I'll be presenting a small case, and then later we'll have a few question answers. So, first talk is by Dr. Stravya. She'll be talking on metastatic HSPC. Over to Dr. Stravya.
Yes, are my slides visible?
Yes, ma'am. Can you zoom out, ma'am? Make it a full screen of slides. Yeah. Fine, ma'am. We can go ahead.
Yeah. Thank you so much, Bayer, for the opportunity. So today I'll be discussing about the treatment landscape in metastatic hormone-sensitive prostate cancer. So to start with, prostate cancer, they may present either as local disease or locally advanced disease or metastatic disease. Initially, they are all hormone sensitive, but eventually they become castration resistant, which is the main problem with the treatment of prostate cancer. So once the patient becomes castration resistant, then there is significant decrease in the overall survival and death. So patients who suffer and die of prostate cancer all have castration resistance. And with the previous available treatment options, the overall survival just improved by 2.5 to 4.5 months, even with the addition of those therapies. So it is important to treat the patients when they are hormone sensitive, because at this phase, the disease has less resistant clones, so that any additional therapy will prolong the occurrence of castration resistance and thus has benefit to the patient and improves the quality of life. Initially, everything is androgen deprivation therapy, and with the addition of these therapies, especially at this hormone sensitive phase, it improves the quality of life of the patient as well. So all the previous studies have showed that the delay in metastatic castration-resistant prostate cancer significantly improves the outcomes. And one such trial is the Stampede trial, which has transformed the treatment of prostate cancer. It is a multi-arm trial which has got multiple arms, where the multiple treatment options were added to the standard androgen deprivation therapy, and it has entirely changed the treatment landscape of prostate cancer. So with androgen deprivation therapy alone, most of the patients will progress to castration resistance within 11 to 12 months. And after castration resistance, the overall survival is just around 3.5 years. And this trial has showed that addition of ADT, anything else to ADT, improves the survival, and the other options were docetaxel chemotherapy or the radiotherapy. Why this radiotherapy has got benefit in these patients, even they are metastatic? It is because in patients with low volume disease who have shown benefit in these trials with the addition of prostate radiotherapy, it means that addition of local therapy prevents the disseminated metastatic clones. And in the patients who already have high-risk disease, where according to this trial, if the patient has high volume disease, like more than 4 bone metastasis, the patient didn't benefit much with the addition of local therapy. It means that if the disease is already disseminated, there is less benefit with the additional local therapy. So the Stampede trial says that addition of radiotherapy or docetaxel to the already being given ADT significantly improves the survival. And there came multiple trials where each and every trial has added either the chemotherapy or additional hormone intensified therapy to the standard of care ADT. And each of these trials, which were done over a period of time for the past 1 decade, have shown statistically significant overall survival benefit with the addition of any of these agents to the standard of care ADT therapy. So we'll be discussing further as to what each of these trials have done. So first is the CHARTI trial, which is one of the landmark trials that has revolutionized the treatment of prostate cancer. So in this study, addition of docetaxel to hormone-sensitive prostate cancer, which is metastatic, docetaxel has shown significant overall survival benefit when it is added to ADT. And this benefit is seen more in high volume disease compared to low volume disease. And this high and low volume disease is basically high volume is more than 4 bone metastasis with at least 1 metastasis outside the axial skeleton or any visceral disease. So these high volume patients, they benefited more with the addition of docetaxel compared to the low volume disease, and the survival benefit is statistically significant with a hazard ratio of 0.63. 16.8 months improvement in OS with the addition of docetaxel. And there came Latitude trial where they have seen if there is any benefit of intensifying the hormonal therapy itself rather than addition of chemotherapy, because chemotherapy itself has got significant side effects. So this trial has shown that addition of abiraterone acetate along with ADT has shown survival benefit compared to ADT alone, and also radiological progression-free survival. So this abiraterone acetate, it was the first one to show hormonal treatment itself can be effective, but this the control arm was not standard in this trial because most of the patients in the control arm had delayed treatment even after becoming castration resistant. But to conclude, this has shown that there is benefit with the, we can omit chemotherapy in some patients and can intensify hormonal therapy adding abiraterone along with ADT. The main problem with abiraterone acetate is because of the mineralocorticoid excess and its mechanism of action, there is hypertension, hypokalemia, and cardiac disorders. So we have to select patients who with baseline no cardiac dysfunction, and serial monitoring for hypertension, cardiac functioning should be done. That is the main problem with the with the addition of steroid, these side effects are pretty much manageable. And this is one of the treatment options in patients with metastatic hormone-sensitive prostate cancer along with ADT. And then comes additional androgen inhibitors, which are second-generation inhibitors, apalutamide, enzalutamide. They were also added as doublet therapy along with ADT. One such trial is Titan trial, which has shown the benefit of addition of apalutamide to ADT compared to ADT alone. And the benefit was seen with respect to progression-free survival and overall survival, both in patients with high volume and low volume disease. So this is also one of the treatment options in hormone-sensitive prostate cancer. And the another drug is enzalutamide, which when added to ADT has shown significant PFS and OS, but the benefit of enzalutamide was seen in patients with low volume disease. More benefit was seen in patients with low volume disease compared to that of the high volume. So all these drugs, when added to ADT in hormone-sensitive prostate cancer, they have shown some PFS and OS benefits. So they are definitely better than ADT alone. So with all this doublet therapy improving the OS, they have further studied if any triplet combination would be more beneficial so as to prolong the occurrence of castration resistance in these patients. One such study is PEACE study, which have selected metastatic hormone-sensitive prostate cancer patients. They are all de novo metastatic. Stratification was done as per charted trial, high volume and low volume. And the performance status was less than 1. If the PS2 because of the bone disease, they are also allowed. They have, this is like a 2x2 factorial design. At the start of the study, the standard of care arm was ADT alone, but eventually many changes were done in the trial where the standard of care has changed from ADT alone to ADT plus docetaxel. So the randomization was done to standard of care with or without radiotherapy or addition of abiraterone acetate. Addition of this trial on further subsequent analysis has showed that addition of abiraterone acetate to ADT and docetaxel has significantly improved the outcomes compared to standard of care ADT or docetaxel alone. And the benefit was seen more in high volume disease rather than in low volume disease. So in high volume disease, the study has shown that ADT with docetaxel and abiraterone patients will respond better and has got improved survival. But this trial was never designed to say whether the doublet would be beneficial or the triplet would be beneficial. It is just an understanding that triplet patients who have received the triplet therapy have done better compared to doublet alone. Then there came this RSN study where they have done the trial to assess whether the triplet would be beneficial or the doublet would be beneficial. So this is a global randomized double-blinded placebo-controlled phase 3 study where they have selected patients with metastatic hormone-sensitive prostate cancer with performance score less than 1 and who are candidates for ADT and docetaxel. So standard of care for the patients is ADT with docetaxel, and then they have randomized the patients to additional darolutamide or placebo along with the standard of care. So almost 87% of the patients in the entire have received all 6 cycles of docetaxel, which means excellent standard control. So the primary endpoint of the study is overall survival, where the secondary endpoint is time to castration resistance or brain progression or skeletal related events, worsening of physical symptoms or pain, and safety of the drug. Adverse events in both the arms were almost identical. The overall, after the statistical analysis has shown that the patients who have received darolutamide have significant OS benefit compared to that of docetaxel with ADT alone. And there is 32% reduction in death. And this benefit is seen both in high-risk patients as well as in low-risk patients. The secondary endpoints, which is like time to castration resistance, time to pain progression, subsequent therapy, or skeletal related events, all in all this darolutamide patients, they are better compared to that of without darolutamide. And the another secondary endpoint is PSA levels which were assessed. This undetectable PSA is considered as a surrogate marker for excellent disease response, and 2/3 of the patients have achieved undetectable PSA levels and hence time to progression. And these patients have better overall survival compared to those patients who have detectable PSA levels early. So almost 2/3 of the patients who have received darolutamide have undetectable PSA or less than 0.2 in the overall study, which has delayed the progression and hence improved the overall survival in these patients. This undetectable PSA is seen more in patients with high volume metastatic hormone sensitive prostate cancer. So more the disease burden, the patient have achieved the deeper and longer duration of response. And this has shown that darolutamide triplet has achieved long periods of no disease progression and hence improvement in overall survival. The same benefit is seen in low volume disease also. Undetectable PSA levels is achieved for a longer duration in patients with low volume disease, and also there was improvement in overall survival. So when to choose what, doublet or triplet, is the standard of care in hormone sensitive prostate cancer. So these are to be chosen based on patient tolerance to chemotherapy, whether the disease is high risk or low risk, what is the life expectancy, and patient needs are to be informed for the options. So good PS patient, young, fit, longer life expectancy, high disease burden, triplet therapy would be better compared to frail patients where we end up with ADT alone or doublet therapy. Thank you.
Can you show? Yes, yes. Thank you, Dr. Stravia. That's a very nice presentation. The next talk is by Dr. Rohit Reddy. He'll be talking on the ARANOTE study.
Just 1 second. I hope my slides are visible.
Yes, sir. You're audible and as well as slides are visible, sir.
Right. Thank you. Thank you so much. At the outset, I would like to thank Dr. Lakshmi ma'am for this wonderful opportunity. Thank you, Bayer team, for giving us tonight so that we can share our knowledge. And most of my work has been made easy by the previous speaker. It was an excellent talk, and she had covered most of the basics of what has happened in metastatic HSPC so far. So my topic would be more of darolutamide in treatment of metastatic HSPCs, and how is it different from the other existing molecules that are already available in the market. So I'll be predominantly discussing on the ARANOTE trial and the evidence which led to its approval. So this is a brief disclosure that the slides have been provided by the Bayer. So this is what has already been discussed so far, that we have evolved from an era where it was only ADT, following which we had docetaxel with ADT in the Charter trial, in the Stampede one. Then came abiraterone. Abiraterone had brought about a phenomenal change in the treatment landscape of metastatic HSPC, because this brought about one of the first oral molecules which led to a significant survival advantage. Then came enzalutamide and apalutamide, but enza is a a drug, as we all know, associated with lot of CNS side effects. So often it's very difficult, specifically in the elderly patients, to tolerate this particular drug. Then came the darolutamide. First, it evolved in the Arasens trial as a triplet combination along with I'm sorry. So first, it evolved as a triplet combination along with docetaxel. Then further, we have now the evolving evidence that it can be used with ADT alone. So there is an unmet therapeutic need always for efficacious treatment that offers a significant improved safety profile for metastatic HSPC. Because previously, many of these patients could not survive beyond 3 to 4 years of therapy due to the lack of availability of any novel therapeutic agents. And the available agents such as abiraterone had significant toxicity, specifically because, as we know, that prostate cancer is a disease of the elderly population. Many of them have comorbidities such as diabetes, hypertension, or underlying cardiovascular disease. In such scenarios, abiraterone makes it slightly difficult to be used. Enzalutamide has its own side effects in form of causing a lot of CNS side effects, fatigue, and all. And the triplet combination is also not for every patient, as previously mentioned, because we know that the median age where prostate cancer occurs is beyond 60 years. Many of them have underlying diabetes, probably neuropathy, which might preclude the use of docetaxel. Many of them have underlying cardiovascular disease. So using docetaxel in such patients may cause fluid overload related side effects. So often triplet therapy is not the answer. Sometimes you just might need a doublet therapy using any of the newer androgen receptor pathway inhibitors along with ADT therapy. So, and one more important thing is that the triplet combination has never been officially compared with ADT and ARPI inhibitor. So we don't know if the combination of docetaxel with any ARPI and ADT is better than an ARPI with ADT alone. So that has never been formally tested. So that's something which we don't know. So having said this, Arano trial made significant leaps and made significance, at least in our day-to-day practice, because it gave us evidence to use one more molecule, darolutamide, along with ADT. And this changed the treatment paradigm. So a brief, in Arasens trial, it was a triplet versus ADT with docetaxel, whereas Arano is essentially the doublet treatment of darolutamide plus ADT versus ADT alone. So this was actually studied because you don't want many people refuse chemotherapy, or many patients cannot tolerate docetaxel. So you need to have evidence behind prescribing this particular treatment. So this was a randomized phase 3 double-blind placebo-controlled trial. The inclusion criteria included metastatic HSPC of a good performance status, proved by biopsy, proven to have adenocarcinoma. The stratification factors used were visceral metastasis, whether they were present or not, whether there was any prior local therapy. And the randomization was into 2 arms. The darolutamide dosage here used was 600 milligram BD with ADT as opposed to placebo plus ADT. It was a 2:1 randomization. The primary endpoint here was radiographic progression-free survival. Now, many people actually argue that though overall survival is the gold standard for many of the randomized controlled trials, often in diseases with a long duration of life or long time period, or with the availability of novel further treatment options which are very good, it is often difficult to find out an overall survival in diseases such as prostate and breast cancer. Hence, now we have evolved into alternative endpoints such as radiographic progression-free survival, So this is now being considered as one of the important endpoints based on which trials can be approved. Of course, the other key secondary endpoints are like overall survival, time to CRPC, time to PSA progression, rates of undetectable PSA, safety. So there are the other pre-specified endpoints like PFS2 and the quality of life scale. So crossover was also allowed here. The median duration of follow-up was nearly around 25 months. So this is a brief description regarding the study design. So these are the baseline characteristics. Interesting to see is that this is one trial which had included a lot of Asian population. Nearly around 30% of patients in either of both the treatment and the placebo arm had Asian population. And there was almost equal representation of the Asian, Latin American, and European population. The de novo metastasis happened in around 70% of the patients. The median PSA level was around 20 in either arms. High risk, high volume disease was almost seen in 3/4 of the patients. Nearly 70% of the patients had a high volume disease. Visceral metastases were present only in around 10% of the patients. Prior local therapy was allowed, and it was seen in around 18% of the patients in either arms. So this is a brief cross-trial comparison showing that unlike the EMBARK trial, the VISION trial, and the COW-A 302 trial, ARANOTE trial is specifically important for us because you can see the maps that most of the other trials, they had a predominant Western inclination, whereas this is one particular trial which tend to show a geographic distribution. There is inclusion not only of the American population, but they also included the Chinese, the Indian population, the South American population. So this is again the regional representation where 15% of the patients were from China, 14% from India, and the other percentages as described. So a significant percentage of the population was from Asia Pacific region. So this was a primary endpoint, which is a radiographic progression-free survival. And the combination of darolutamide with ADT has definitely achieved its primary endpoint. The landmark of 24 months, as you can see in the particular Kaplan-Meier curves, there is a wide separation of the curves. The curves started separating from as early as 3 months, and there is a uniform separation throughout the study duration. At the landmark analysis, you can see that it's 70% patients who are progression-free in the treatment arm as opposed to 52% in the placebo arm. And the median radiographic progression-free survival has not been reached in the treatment arm, whereas it is around 25 months in the placebo arm. The hazards here are 0.54. This is one of the trial which had shown a very good hazard ratio. So there is almost nearly around 46% reduction in radiographic progression-free survival. The p-value again here is less than 0.001, which is significant. So whenever a particular trial has shown a good radiographic progression-free survival, you also want to dissect its subgroups, see if it's really effective in one particular patient population, or is it effective across all the various subgroups. So any trial that is showing a significant benefit in all the subgroups tends to portend that this drug is really effective. So here also in the forest plot, you can see that across all the various subgroups, irrespective of the age, the baseline PSA, the performance status, the Gleason score, the disease volume, irrespective of the race, region, and presence or absence of visceral metastasis, this drug was nearly effective across all the various subgroups as evident by the forest plot. So but one interesting thing to actually note is that this particular drug is more effective in low volume disease as opposed to the high volume disease. One particular explanation for this particular interesting phenomenon, which is seen in the other apalutamide and enzalutamide trial, is that A low volume disease tends to have a less disease burden, probably less mutated clones, and a complete androgen blockade brought about by both ADT and darolutamide. Darolutamide not only acts at the receptor, it's not only a receptor path, it's not only an anti-androgen drug acting at the androgen receptor, but it also inhibits the nuclear translocation. This entire phenomenon causes a complete androgen blockade. And specifically, if you have a low burden disease, there is a lot of benefit by adding this androgen receptor pathway inhibitors, because specifically it delays the time for development of a further mutated clone. So these are other key secondary endpoints, like the combination of darolutamide and ADT. It demonstrated a benefit across all the secondary endpoints. The median overall survival data is immature at the time of primary analysis. This trial is still ongoing. The patients will be followed for further survival. But numerically, if you see, it's slightly tending to favor towards the darolutamide arm. The time to MCRPC, this is also important, because once the patient goes into the phase of MCRPC, though you have availability of further treatment options, his disease course is going to go downhill. So you don't want to become the patient into the phase of MCRPC. So any drug which can delay the time to MCRPC is supposed to be a very good drug. So here also, this particular, you can see that it's the hazards are almost 0.4, and they're within the boundary of confidence interval. The time to PSA progression. See, for us, yes, definitely we get a radiological imaging probably at end of 3 months or maybe 6 months of therapy. But I think many of us, what we do at least is that whenever we start a patient on particular drug, be it Daro or enzalutamide or apalutamide along with ADT, we check PSA within 1 month. So as soon as the PSA starts coming down and the patient starts subjectively feeling better, he tends to have faith in our treatment. So a PSA decrease is always better for the patient. Subjectively, this is the only value that he's really interested in. And as soon as his PSA previously, which was maybe more than 100, starts coming down maybe less than 10, so he's really happy. So if you decrease the time to MCRPC, if there is a good PSA suppression, the time to subsequent cancer therapies also gets delayed. And eventually the time to pain progression, this is also one key secondary endpoint. So if you see, most of the secondary endpoints, they tend to favor the combination of darolutamide with ADT. Again, this is a Kaplan-Meier curve, which shows that the time to MCRPC with Daro and ADT has not been reached. Whereas in the placebo arm, it's only 13.8 months. The hazards here are 0.4. The time to pain progression is also significantly delayed with darolutamide and ADT as opposed to placebo with ADT. Again, the hazards here are 0.72. Now, the delay in time to progression can be of high importance to patients, and this has not been demonstrated with any other AR inhibitors till date. So this is one parameter which has been studied, and this is a very important subjective parameter because it indicates that the drug is also improving their subjective feeling of pain. So now again, whatever we have described, that the PSA less than 0.2 at any point of time or a deeper and durable PSA responses are seen with darolutamide and ADT. This is very important specifically for the patients because this is one value which they'll always be particular. Most of my patients are particular whether their PSA is going up, going down, what is it jumping like. So they're very sensitive about this. So if you have a drug which can suppress the PSA to the maximum level, that is one of the best treatments that you can give to them. Similarly, time to PSA progression with the Daro and ADT, the median has not been reached, whereas with the placebo and ADT, it is almost 16.8 months. The hazard ratio is 0.31. So this is a drug which also causes deeper and durable PSA responses. A higher proportion of patients achieved undetectable response with darolutamide versus placebo, irrespective of whether they had high volume disease or low volume disease. So this tends to depict that this drug is effective irrespective of the volume of the disease. Though definitely one interesting point is that it is more effective in low volume disease. The delta of difference is higher in low volume disease. That's probably because a lesser burden means lesser development of resistant clones. So at any point of time, if you see the high volume disease, the PSA suppression was 54.6 months, 6% in the Daro and ADT arm versus 15% in the Daro in the placebo arm. Whereas in low volume, the PSA suppression was almost to the tune of 82% versus 25% in the placebo arm. So they've also studied what was the subsequent life prolonging anti-cancer therapy. So this is a subsequent treatments. So nearly around only 32% of the patients have received subsequent life prolonging anti-cancer therapy in Daro ADT arm, whereas in the placebo arm it was nearly 42%. So 10%. So irrespective of the crossover, nearly subsequent treatments happened in 42% of the arm. So now if you dissect what are the subsequent treatments, it's docetaxel in most of the patient. Around 25% of patients went on to receive docetaxel. Around 10% of the patients received abiraterone. Only 3% received enzalutamide in Daro arm, whereas it was 7.5% in the placebo arm. Apalutamide 1.5%, subsequent like cabazitaxel, radiamide, olaparib, few patients. Okay. And patients who discontinued the study treatment. So it was only 45% in the Daro with ADT arm, whereas it was 71% in the placebo and ADT arm. So you have a safe drug. You have found out that you have a drug which is actually effective. It is causing benefit both in subjective and objective terms. Now the second thing is you have also worried about safety, because a drug which improves the progression-free survival, which looks fancy on the Kaplan-Meier curves, in case if it does not, if the patient cannot take this drug for a prolonged period of time, then I would say that it's not going to be successful. So hence, safety-related data is always going to be important. So this was the incidence of the adverse event between both the treatment and the control arm. So if you see, any adverse event was almost equal. It was 90% in both the arms. If you see the grade 3 side effects also, it was 30% in both the arms. Serious adverse events were 23% on both the arms. So this drug appears to be very safe. So treatment related discontinuation was only 6.1% in the Daro arm, whereas it was 9% in the other arm. So why is it higher in this particular setting in placebo arm? Because the disease tend to progress, and whenever a patient particularly progresses on his ADT alone with placebo, then obviously he's going to have more and more side effects. So after observing for a median duration of 24 months in the treatment and 17 months in the placebo arm, the treatment related adverse events were almost similar. The discontinuation was lower in the Daro arm. So this is a dissection of all the side effects. You see, most of the side effects are almost okay, manageable and all. The side effects which were more common in the treatment arm were something like constipation, hot flushes, mild hepatic derangement and all. Interestingly, fatigue is lower with Daro and ADT arm. This is one important thing because fatigue tends to be slightly higher with enzalutamide and abiraterone. So interesting to see that fatigue is slightly lower with darolutamide and ADT. So this is again the slide which shows that most of the side effects, they are similar across the either treatment arms, whether it was hypertension, incidence of diabetes. Fatigue was lower here. The bony fractures were slightly higher. It was 4% versus 2.3. Again, like any other ARPI, the coronary artery disorders were slightly higher. It was 3.6%. But if you see, as opposed to abiraterone or maybe enzalutamide, it's slightly still on the lower side. And the interesting thing is that because this molecule does not actively penetrate the blood-brain barrier, the CNS side effects such as cerebral ischemia or psychiatric issues or mental impairment disorders are slightly lower with darolutamide. This is predominantly because though they are all androgen pathway inhibitors, there are structural chemical changes. So because of the structural chemical changes, this particular drug does not actively penetrate the blood-brain barrier, and hence it leads to lower CNS side effects. And this is one really interesting point which the company usually focuses on. So you have a safe drug, you have an effective drug. Now you are also interested in knowing the impact on the health related quality of life. So the FACT-P trial had shown that darolutamide extended the median time to deterioration by around 5.1%. This was presented in the ASCO 2025. And this is the first and only AR inhibitor to demonstrate clinically meaningful delays in progression of pain and overall well-being. So even if you see on individual subjects of the FACT-P pain score subscale, so both social and family well-being, functional well-being, urinary symptoms, darolutamide tend to do better. So concluding, so this is a very effective drug in metastatic HSPC. It is one more option to the already existing therapeutic armamentarium. It is a drug which has probably less incidence of side effects, probably more tolerable as opposed to the other existing ARPIs. And it had shown significant benefit across all the secondary endpoints. Overall survival is still pending, associated with a deeper PSA response regardless of the baseline PSA. And it has limited side effects. It is the first drug that had shown improvement in pain progression, overall well-being, such as social or family well-being, functional well-being, and urinary symptoms. So darolutamide with ADT without docetaxel should become an additional standard of care for metastatic HSPC. Thank you. Thank you for the opportunity.
Thank you, Dr. Rohit. That's a very lucid presentation. Now we'll be discussing the real world scenarios. Still now we have seen the trial data. I'll present a small case which we did in our hospital a few years back. And then following that, we'll have a question and answer session. Let me start sharing my screen. I hope my screen is visible. Is my screen visible, Dr. Rohit?
Yes, ma'am, it's visible.
Yes, ma'am.
This is a case of a 67-year-old man who underwent evaluation for obstruction in flow of urine, blood and urine. He had history of hypertension, diabetes, mellitus for 20 years. And when he presented, the investigation was suggestive of urinary tract infection with high serum PSA. PSMA, PET-CT, and transcript biopsy were done. His PSA at the time was, you can see it's in 2025, it's more than 153 nanograms per ml. This is the gallium PET-CT. Yes, this is a that showed PSMA expressing locally advanced prostate primary and PSMA expressing cervical, supraclavicular, mediastinal, abdominal pelvic lymph nodes, mesorectal nodes, and skeletal metastasis. This is the transcardiac biopsy. Let me show the final impression. This is showing adenocarcinoma prostate, intraductal with the Gleason's of 9. Okay, so now we have a patient of metastatic castrate-sensitive prostate cancer, which is high risk and high volume. He was started on triplet therapy with Degarelix, docetaxel, and darolutamide. He was also started on antibiotics as for UTI as per culture reports. He improved symptomatically in a month, and serum PSA levels in March was more than 153, in April 0.92. March to April, within a month, you can see it came to 0.92, in July 0.2. So the PSAs continue to remain low, and he improved near normalcy and was continued therapy. So that's about it. So you can see, especially in patients with comorbidities, and this patient actually was not started on. I didn't show you the report. Actually, was planned on other drugs, Enza and apalutamide. Enza was not given fairing falls, and apalutamide, no, he already had UTA. So all these drugs, they need to combine with the steroids. So the plan was to start with darolutamide. That's about it. We'll next discuss about, we'll have the question and answers. How do I stop sharing my screen? Yes.
Ma'am, before that, sorry to interrupt. I think there is
Yes.
one question in the chat box. If you can take up this question now.
Yes,
A question
yes.
from Dr. Anand. Can you see now?
Do you foresee genomic alterations such as BRCA1 and 2, ATM, CDK12, or TP3 influence the choice of between upfront and doublet versus triplet therapy in the future, as we are all still far from biomarker-guided treatment selection in metastatic HSPC? See, as of now, even the patient has BRCA1 and 2 or any genomic alterations, we are not changing the treatment, upfront treatment. These inhibitors, PARP inhibitors, they have a role in the later lines, especially in prostate. They're not giving a dramatic change. The PFS improvement is, though it's seen, it's not so high. So, as upfront therapy, the choice doesn't change. This is my opinion. Dr. Rohit, what is your opinion on this?
I agree, ma'am. As you have rightly pointed out, right now there is no evidence telling that the upfront PARP inhibitors are going to bring about any extra benefit as opposed to the existing doublet-based treatment. So maybe in near future we might get more changes, but as of now, still it's going to be either a doublet or triplet.
Yes, yes. I have a few questions. So I'll start sharing. So, Dr. Savia has beautifully described the evolution. She described about the other trials also. So I won't be going with this thing. We'll take a few questions. Which patient phenotypes, disease volume, visual involvement, symptom burden, finality most clearly tip you towards ARA doublet versus triplet? In short, how do you choose a doublet? How do you choose a triplet? Dr. Stavia, can you give you already described, but I want to hear from you. Yeah, in a real world, how do you choose?
Yes, ma'am. While choosing doublet versus triplet, we usually consider the disease burden and also the patient comorbidities, because ADT has to be given in all these patients, but intensification with even more hormonal therapy or chemotherapy, they have their own side effects. So most of the times it is the PS, disease burden, and the comorbidities which decides whether it is triplet or doublet. If the patient is fragile, we end up giving doublet. And if the patient is young, fit, good performance status, then triplet would be the better choice initially.
Dr. Rohit, as an extension to this, have you ever started with doublet and added a third agent? In your practice in real world, sometimes when you think that adding chemotherapy will do better thing after a few weeks of patient stabilization. Did you ever do it? Did you ever think about that?
Yes, ma'am. I've done only in one patient. That too because I was not happy with the kind of PSA response that the patient was having. So it was a patient who had probably a PSA of around 600 or 700. I don't remember. After the dilution, I've started him on a combination of ADT and one of the ARPI. After 1 month, I did not see a very good PSA response, nor any improvement in his symptom. So I felt that this particular patient might benefit probably by treatment intensification. So that was the only case where I have actually intensified my treatment. But otherwise, what I was just telling, so we do not have any proper data telling us that a combination of ARPI and ADT is inferior to a triplet treatment. So right now, we don't know whether a combination of ARPI and ADT is inferior to triplet treatment. We have data definitely telling that docetaxel and ADT is probably inferior to the triplet combination. So where I would definitely push a patient towards triplet therapy is probably if it's a younger patient with a good performance status, if he has a heavy burden of disease, preferably with more of visceral metastasis. In such condition, if I feel that patient needs a rapid response, he might sink down if he do not has a rapid response. So that's one particular scenario where I would definitely push for a triplet based treatment. But otherwise, if it's a low volume disease, you think that patient is going to do okay, you want to avoid docetaxel related side effects, a doublet is even good enough till this date now.
Yes, in fact, when we think of triplet, the initial days, we had a fear the patient would tolerate or not. In those patients, actually, we used to go slow. In some patients where they were very frail, there was a time when I gave doublet for a month and added docetaxel in the next month. That is why I thought I should ask this question: what your practice is. So, coming to next question, when abiraterone or enzalutamide combinations lead to feel suboptimal, what are the most common clinical or practical triggers? What are the most common practical triggers? Steroid requirements. No, I don't think. See, let us change the question. What common side effects you see with abiraterone or enza in your clinical practice when you're using abiraterone for days together and enza for days and months together? What toxicities you commonly encounter? Dr. Stavia?
Yes, ma'am. Abiraterone with single dose 5 mg steroid is pretty much tolerable, except for in some patients who end up with hypertension or dyselectrolemia. But most of the times, patients are pretty comfortable. Only thing is, it has to be taken on empty stomach, and most of the patients complain about taking on empty stomach. Other than that, with 5 mg prednisolone, most of the patients are doing fine. Enzalutamide, fatigue. I feel fatigue is the most common side effect with patients usually complain. And
Have you
some
noticed
cognitive.
fall with enza in any of your patients? Because falls are something which everybody fear, and that is the most feared complication. Falls
Yes.
with enza.
Enza, I have actually given in only just one patient and have started
Okay,
1 month, so I just want
okay.
to know.
Dr. Rohit, what is your experience with abiraterone and enzalutamide?
Having said everything, ma'am, I think still abiraterone is the cheapest drug that we have.
Yes.
So still we use abiraterone in most of the patients. At least 90% of them tolerate it pretty well. The only issue, as Dr. Shravya has rightly pointed out, is that probably that steroid 5 mg might cause some diabetes, or it might lead to some diabetic related complications in some of the patients, hypertension, and maybe mineralocorticoid related side effects. These are the only things that bother some of the patients with abiraterone. But otherwise, it's a pretty much safe drug. And in some patients, like for example, what I have noticed was whenever you try to use it as a low dose abiraterone with low fat meal, so that's one particular indication where I feel that I don't think even these mineral corticoid related side effects are even more prominent. Enza, as you have rightly pointed out, ma'am, at least a few of two of my patient, one patient had major cognitive dysfunction, one patient had seizures with this particular drug, so I had to switch them to a different drug. But irrespective of that, because it causes minor cognitive impairment in many of the patients, we are really worried about the falls. And as we all know that in this particular age and with this particular malignancy, they are at high risk of developing fractures. So one needs to be always cautious whenever they're starting ENZA. And fatigue, yes, definitely is higher as opposed to either an apalutamide or a darolutamide.
Thank you, Rohit. Here I'd like to share my experience. There was a time when darolutamide was not available and there was no, triplet also was not the standard of care. We used to just sequence one by one. And I had a patient who was on abiraterone for quite a long time, almost nearly 2 years. And one fine day he developed proximal myopathy. Actually, initially the symptoms were very weird, more like neurological. And finally we thought it's proximal myopathy, though muscle biopsy was not done at that time. And the myopathy was so severe that he could not, he getting up was a big problem. Later on, in due course, even walking became a problem. Even after stopping steroid, that debility continued for quite few months. That time, darolutamide was not available. I really had a tough time managing the patient, and that was a bad experience, which I faced with the prolonged use of abiraterone and steroid. There's Enza is though falls are overhyped, I feel, because falls are not very commonly. But if the patient has neurocognitive effects, yes, that's a very, bad side effect, and you just cannot forget the experience if you see the patient with the neurological effects with the enzalutamide. These are the two things which I thought I should share with you. Next question, which aranode strengths most impact adoption versus currently approved doublets? We will consider aranodes hazards to other ARS, and how does it affect the first line combination? Yes, I like to add here because we were actually using darolutamide even before this aranode study. This aranode actually adds to what we are, it just gives evidence to what we are doing. Because the combination was already being used. Even in fact, I have been using even the start of the study, but we could not openly tell that we have been using because initially the drug was approved only for non-metastatic CRPC, and then again the approvals, it increased. So we'll take the next question. How do the volume data clarify the appropriate patient for treatment intensification darolutamide with docetaxel? Does the ADSENSE data support use of darolutamide plus ADT with docetaxel in low volume metastatic HSPC? What about low volume is the question. Low volume versus high volume. Dr. Stavia?
In low volume disease, initially start with doublet therapy only, ma'am, because additional triplet therapy, most of the times patients won't be willing and it will add to the additional finances. So we'll start with doublet. If the response is not satisfactory, then we add sequential third drug, yes.
Yes, especially the volume decides as to what combination we are giving. In your practice, what characteristics define patients who are ideal candidates for development doublet versus alternative regimens? One or two characteristics, Dr. Saravia? Doublet versus when you choose darolutamide or when you choose other drugs?
It's mostly the side effect profile and the comorbidities of the patient. What side effects will the patient be able to tolerate, what not? So that decides the choice of therapy most of the times, ma'am.
Yes, and if you ask me, I almost always use darolutamide, except for the patients when the patient cannot buy.
Yeah.
And how do potential drug-drug interactions influence your decision-making when selecting PAR, ARPA-based regimen in patients, and what strategies do you manage these concerns? These drug-drug interactions, have you noticed any, in your practice, have you come across any bad drug-drug interactions? Dr. Rohit and Dr. Sharia, we'll start with Dr. Rohit.
No,
Drug-drug
ma'am.
interactions in your experience?
Not really, not actually.
Yeah, okay. Dr. Stavia?
No, ma'am.
Yes, actually, as because the prostate cancer patients somewhat they are in a healthy patients, except for the fact that initial phase they'll have difficult, but once we stabilize them, they almost tolerate the therapy well. Drug interaction somehow I too have not faced any big issue, but if the patient is on anti-epileptics or other drugs, if the patient is on medication for tuberculosis, anti-tuberculosis, ATT, and all this, and the patient is on other HIV positive, all this, we need to be very careful. So fortunately, even in my practice, I have not seen any bad drug interactions. So what about the treatment sequencing to preserve options? How do you sequence this? Now we have so many drugs available. What is your plan of sequencing, Dr. Rohit?
So I think
Or
what
yes,
I would generally do is this is similar to the first question that has been asked, ma'am. So nowadays we have an option of choosing both triplet therapy or doublet therapy. So
yes,
wherever possible, I think most of the oncologists, at least in Hyderabad nowadays, we are tending to prefer triplet treatment if the patient can afford it and probably tolerate it. So having used triplet therapy in the first line, subsequent line of management slightly becomes more difficult because you are using three eligible options in the first line setting. So subsequent treatments, if I've used a triplet therapy in the first setting, would depend on whether they have a HRR pathway mutation. So if they have a HRR pathway mutation, then I would rather tend to put them on olaparib. If they do not have a HRR pathway mutation, the other approaches, the other treatment options that are there are lutetium 177 PRRT PSMA based treatment. We also have cabazitaxel. We also have radium based treatments, and there is also evolving data of probably cabozantinib and atezolizumab in further lines of therapy. So these are subsequent treatment lines which I would be thinking of, ma'am. If I've gone with a doublet based treatment, then at the subsequent progression, it would be the agent which I have not used. If I've used a docetaxel with ADT, then I'll go on to one of the ARPI inhibitor. If I've used ARPI with ADT, then docetaxel subsequently. So this is what we do.
thank you. That's a very nice and clear explanation, Dr. Rohit. Starting with this question, I think you can take. I'll just read it out. It's a 68-year-old man with de novo high volume metastatic HSPC, ECOG2, diabetics, hypertension, mild neuropathy, and he's reluctant to receive chemotherapy. Would you recommend Arasen style triplet, Aranold style doublet, or begin with ADT plus darolutamide and reserve chemotherapy for progression? What factors would drive your decision? This is the question which is posted in the box. High volume metastatic HSPC.
So high volume metastatic disease, but he already has diabetes and neuropathy, doesn't want to take docetaxel. He already has hypertension, so abiraterone, we don't know how he tolerates. So according to this question, maybe ADT plus darolutamide, ma'am.
Yes, that would be a better option, especially when we have old patients. In fact, what is the oldest patient whom you treated of CA prostate? The oldest, I mean, as per age?
I have seen one patient who is 90-year-old who presented with high volume disease, and his PSA is somewhere around 600. I have never seen such high PSA. So we have done orchidectomy for him, but unfortunately he didn't come back again.
Dr. Rohit, your patient, youngest and oldest?
I've treated 87, ma'am.
Okay.
It was with a combination of leuprolide and low dose abiraterone. He was doing fine for probably 1 year. Later expired because of some coronary artery disease or something.
Okay, okay. I have seen the oldest is 92-year-old, 92. And I think he's still alive. I'm not, because last few months I did not see him. Last year, yes, still last year he was there, 92-year-old. And yes, prostate cancer actually is a disease of the elderly, but we are seeing these days in younger patients also. What is the youngest age patient whom you have seen, Dr. Rohit, youngest age?
I think it was somewhere around 50 or 55, ma'am. I don't remember.
Yes, yes, around 55. Even I have seen 55. It is sad that we are seeing prostate cancer these days in young age group. That's a sad part of it. So this is the 2026 treatment message. ADT backbone is essential. Androgen deprivation remains the foundational therapy for all metastatic HSPC treatment strategies, providing essential testosterone suppression. ADT alone is obsolete. Here, ERPA tablets are standard. ERPA plus ADT combinations represent the current standard of care for the majority of metastatic HSPC. And three approaches, ARPS provide treatment flexibility, allowing selection based on patient-specific factors. And triplets are aggressive disease. Triplet combinations offer greatest survival benefit, particularly for fit patients with de novo high volume disease. Patient fitness essential assessment is crucial for triplet consideration, including performance status and evaluation. I thank Stavia and Rohit for their excellent inputs and their presentations. Thank you, Bayer team. Thank you, Sandeep. Over to Sandeep.
Ma'am, thank you, ma'am. Before we close, I think we can see one more question in the chat box, ma'am. I think it is posted by Dr.
That was already discussed.
Yeah,
That is the reason
okay,
why
yeah.
I didn't discuss that.
Yeah, thank you, ma'am. With this, I think we are end up to the session. So my sincere thanks to Dr. Meher ma'am for taking time, and I also thank to Dr. Rohit Reddy sir and Dr. Sravya ma'am for your insights on RSNs and RNO data. So I thank you all the faculty and all the attendees who have joined the meeting. I think we can see around 37, 38 plus audience who have joined in this meeting. I hope, ma'am, definitely it is added value to the day-to-day practice for the treatment for the patient's benefit of prostate cancer. With this, we can conclude the session, ma'am. Thank you so much for your time. We can log out the session.
Thank you. Thank you, one and all.
I request technical team to end up the session.